right, welcome everyone to this week's edition of It's Worth a Shot. Today is November 9th, 2022, and this happens to be the 43rd edition of our weekly open office hours. And today we'll be discussing immunization recommendations for patients with diabetes and diabetes management in the elderly, really in celebration of November being National Diabetes Awareness Month. Welcome everyone. Next slide, please. So as usual, special thank you to all our speakers and partners and attendees. Please reach out if you have any ideas or feedback or would like to be a guest speaker. We couldn't do this without you. We've had continual growing participation and we appreciate you all. Next slide, please. As mentioned, we'll continue to meet every Wednesday. Next slide, please. And polling question. Our facility uses the following tools for routine vaccination reminders. Looks like some options are, we use EHR, we don't really manage the follow-up vaccines recommendations, you use your state IIS system or other enter in chat. I'll give everyone a few moments to participate in the polling. As always, we appreciate the participation that helps gauge and align educational resources and identify barriers. Looks like so far, most folks that have answered are utilizing their electronic health record to track routine vaccine reminders. We'll see if we can get a couple more folks to participate in the polling question. And we will close out in just a few seconds. All right. Looks like most use their electronic health record to track routine vaccination reminders. And there's a few that also use the immunization information system. All right, thank you as always. And we have been sharing, for those of you that have been participating the last several weeks, we've started to incorporate our weekly influenza snapshot from the CDC. And this last reporting period, we have continued to see an increase in flu rates. Mostly, it looks like flu A, and we've also seen a couple of pediatric deaths now to date. Of note, last reporting period, we were seeing steady about a 5% increase in flu cases. That has jumped to a just over 9% increase now as far as mortality. Influenza activity continues to increase through all of our regions, and it looks like region 3 and 9, so South Central, West Coast, and Mid-Atlantic are seeing the highest levels of flu activity at the moment. So again, just a friendly reminder, get your flu vaccine. All right, next slide, please. So without further ado, I'd like to introduce our very own Kyla Newland as she discusses immunization recommendations for patients with diabetes. Kyla, it's all you.
Thank you, Jessie, and thank you everyone for attending today. You can go to the next slide. Why is vaccination important? Specifically for patients with diabetes, it's very important just because the underlying disease process of the disease, it really can affect every kind of organ system and system micro and macrovascularly of the body. So people with diabetes just don't have as much capacity to fight infections and can have a reduced immune system. Based on, of course, the level of control they have over their diabetes. Higher than normal blood sugars can be observed when people are sick. And so if you're already having increased blood sugar levels and then you get sick, that can lead to worse outcomes and really work against you as your body is trying to fight infectious diseases. Also, they have higher risks for serious problems, as I mentioned, and I will talk specifically about some of those things that we're seeing and what causes that in patients with both influenza, diabetes, hepatitis, and other infectious diseases. Next slide, please. So influenza in and of itself, and most viruses actually, because of the kind of immune response and then an increased level of stress hormones like cortisol can raise your blood sugar. As I mentioned, that can make it harder for your body to fight infection. People with diabetes actually have higher rates of hepatitis B than the rest of the population. And also outbreaks of hepatitis B have been associated with blood glucose monitoring procedures among patients with diabetes, which is a really interesting statistic that I was not aware of. And also people are at increased risk for death from pneumonia. If folks contract pneumonia, they can also get bacteremia, blood infection, meningitis, and these are all increased risks in patients that have diabetes. Next slide, please. So what does the CDC recommend for these folks specifically? So we know that everybody's indicated to get an influenza vaccine, everybody 6 months and older. Additionally, pneumonia vaccines, as we've gone over kind of in some of our previous sessions with the pneumonia vaccine, it's recommended for those with the higher risk conditions, and diabetes is listed as one of those for folks that are between the ages of 18 and 64. So that is a reason to get your pneumonia shot at a younger age. Also tetanus, diphtheria pertussis, or Tdap vaccine, as we call it. That is recommended for all folks every 10 years, but just making sure that's on the list for folks that do have chronic disease like diabetes. Shingles vaccine, that vaccine is recommended for those 18 and older that are at higher risk for or have immunocompromising conditions. Diabetes is not specifically listed, but it is recommended for patients with diabetes, and it is recommended for everybody age 50 and older. If we think about the disease process that happens with shingles, or can happen with shingles long term, we think about neuropathy, which can be this kind of lasting nerve pain because the virus lives in the nerve plexus. And so in patients with diabetes, they're already predisposed to this disease process. And so it can be even kind of more devastating for this population. As I mentioned earlier, the hepatitis B vaccine, and then of course, COVID-19 vaccine. And I'm going to go a little bit more in depth to look at kind of some of the reasons why patients that get COVID-19 and have diabetes have worse outcomes. If there's any questions, if you would monitor the chat for me, Jesse. So we can go to the next slide. So we know statistically that looking at all the data from COVID-19, that these patients have a higher chance of having serious complications, including severe illness, ICU, death, and other adverse outcomes. So very important to make sure that these folks are vaccinated and that they're aware of kind of some of the things and the risks that are there for them if they do contract COVID-19. So comorbidities, a lot of people with diabetes have comorbidities, as we know, including chronic kidney disease, COPD, cardiovascular disease, and also hypertension. The disease process of diabetes itself is considered a hyperinflammatory state. And so we know with COVID, essentially we get this hyperinflammatory kind of cytokine storm when our body gets exposed. And this can be just aggravated if we're already kind of in that state. The impaired immune function, which I mentioned earlier. And then I'm going to talk about a couple other things that are really kind of specific and really emerging as far as research. But we think that patients with diabetes might have an altered kind of mechanisms for DPP and the renin-angiotensin system. because COVID can affect these systems in our body. So this is kind of looking a little bit more into the weeds of kind of the pathophysiology of what we see. And I actually have a chart on the next slide, which kind of just looks at the renin-angiotensin system, which is basically angiotensin is a chemical in your body that causes vasoconstriction. And so what we see in patients with diabetes is that they have potentially an increased kind of upregulation of this system. And the SARS-CoV-2 virus actually uses this receptor to get into your lungs. And if we're hypersensitive to it or overexpress it, it might be causing more damage, including potentially increased insulin resistance, which we already have in these patients, reduced blood supply to our pancreas cells, which produce insulin. So just kind of aggravating the disease state. And so I thought this chart kind of illustrated some of the things that can happen. This is, again, kind of a theory. We don't know this for sure, but we do know that COVID does use this ACE2 or angiotensin 2 receptor to get into our body. Next slide, please. And the other one that I wanted to talk about that I didn't have a picture for was DPP. If any of you are familiar with some of the drugs that we use to treat diabetes, the DPP-4 inhibitors are one of the drugs that help our body use insulin better. Basically, those are drugs like Januvia and Onglyza, Tradjenta. So if patients have an upregulation of that system, they may not be able to manage COVID as well. So kind of another interesting pathophysiologic mechanism. So I see Jesse's asking, has anyone noticed a change in insulin demand with diabetic patients? Yeah, so that kind of leads right into this last slide here. And some of the research that's coming out, and it's not conclusive yet, it's kind of in early phases, but we are seeing in some studies, and this study particularly that I was looking at was done in the VA population. And so it was a large study. And they looked at 181,000 participants who had a positive COVID test during kind of the peak time frame for COVID, and they had survived 30 days post. And they compared them to two groups that were prior to COVID that had not had COVID. And they did find that at a 12-month period, the burdens of incident diabetes and anti-hyperglycemic use compared with the control group were higher. So they're actually seeing in some other studies increased like rates of diagnosis of diabetes in patients that have had COVID. So they're not sure if this is related directly to them having COVID, or this could be something included in kind of the long COVID, or maybe these patients delayed treatment for their diabetes or for, potential diabetes diagnosis during the pandemic. And so we're seeing increased rates of diagnosis, but there is quite a bit of research kind of coming out about this. So keep your eye out, and we will definitely see if we have any more kind of conclusive answers. But it is alarming given that our rate of diabetes is already pretty high. And as Aggie, I believe, is going to talk about patients with prediabetes is really high as well. So, if something like COVID could push them over the edge into that diabetes, that, is something that we need to consider. So I think that's all. These are my resources. These are some nice handouts that talk about patients with diabetes and which vaccines they need that you can actually provide to patients. I will mention that some of these don't have COVID-19 vaccine on them yet because they just have not been updated. But obviously, we know that that is a definitely recommended vaccine that we need to be talking to our patients about. So Aggie, I will turn it over to you unless there's any other questions.
Thanks, Kyla.
Okay, so I guess I'm on. Thank you very much for having me, everyone. Half a day, hello, and welcome this morning, or rather this afternoon for you all. I think I'm 17 hours ahead of you all, so welcome to the future. I've taught diabetes self-management education for a while, and I'm glad to be here to share with you some of the things that I have learned through the years. And it's an appropriate time to talk about diabetes because November is National Diabetes Month, as promoted by the American Diabetes Association. So this afternoon, if we could go to the next slide, Mary, please. We're going to talk briefly about the ADCES 7 self-care behaviors. We're going to talk about hypoglycemia, what it is, discuss some risk factors, some ways to prevent it, treatment of hypoglycemia when it does occur. I forgot to add this one in. We'll also talk about an alert strategy to consider for your staff use whenever you have to notify a medical provider of blood glucose levels on some of your residents. And then lastly, we're going to talk about me, but not really me, it's you that we're going to talk about. Okay, so the audience I usually work with are people with diabetes, their families and caregivers who by and large perform their own self-care. But in your situation in the nursing homes, I'm going to assume that you, the staff, are the ones that are doing most of the self-care management for your residents. Now, managing diabetes successfully is challenging for anybody at any age. But I would think that it would be especially challenging since the elderly is a unique population with specific needs that have to be addressed. Although older adults with diabetes have higher rates of premature death, functional disability, accelerated muscle loss, not to mention comorbidities like hypertension and coronary heart disease and chronic kidney disease and stroke. And if you think that's a lot, let's complicate things further and throw in some common geriatric syndromes like polypharmacy, cognitive impairment, depression, urinary incontinence, injurious falls, persistent pain, and frailty. And then what do you get when you have to try to manage all this? Next slide, please. You get an overworked charge nurse that has to use the resident's wheelchair to get right here. So yes, managing diabetes in the elderly successfully can be difficult and challenging, but not impossible. Okay, for a person to manage diabetes well, there are certain self-care behaviors that they need to perform. The ADCES, which stands for Association for Diabetes Care and Education Specialists, have a helpful model, which they call the ADCES 7. So it's the 7 self-care behaviors that I identified would help a person successfully manage the diabetes. So if you can type into the chat what you think some of these self-care behaviors are, we can go ahead and discuss it from there and take it from there. So just go ahead quickly, okay, exercise. So there's 7 self-care behaviors. Diet, okay, that's Jesse and Kyla. Appointments, very good. Anybody else? Okay, we have exercise also. Excellent. Okay, education, medication, relaxation, these are all great, the sleep. And each of these that you're all mentioning fall into one of the categories that I'm going to just talk briefly about. Okay, Mary, can we click on the link and then so they can see the graphic that the ADCES puts out to display these 7 self-care behaviors in a very nice image. Okay, so let's see, where is that graphic? There it is. If you see it, it's I think, there you go. See that 2 people in the middle with these concentric circles there? Sorry, we can't really see those circles and what they say, but I can go ahead and speak about it. And some important things about this model, this framework. It's called the ADCES 7 self-care behaviors framework. Is if you in the middle you see you have the people, and around that you have healthy coping. Healthy coping is the behavior that has to be first addressed because learning cannot happen until healthy coping occurs. A person's mental and emotional health is very important. And I know in the nursing home situations, This might be difficult to assess since cognitive decline might be more common than in the regular population. Nevertheless, to the extent that you can and are able to assess for mental health status, please do so. In the resource page at the end, I do have some resources from the Alzheimer's Association and the National Institute for Health describing tools, assessment tools for accessing cognition. So healthy coping is very important. It's also important to assess for depression, because depression and people with diabetes, whether you're an elderly or not, have higher rates of depression. And that's understandable since it takes a lot to manage successfully your diabetes. So you really have to see and assess for depression as well. And with the elderly, we know that depression can be, and it's probably higher, has higher rates in the elderly. So please assess for depression. And so these have to be addressed because you can't teach, you can't do any teaching unless, they're in a mental, emotional place that's healthy. And healthy means healthy coping is a good attitude about their situation, about their diabetes, about their relationships with other people. So that's important to discuss with your clients, as well as for any of you, if any of you have family members or you yourself are struggling with diabetes, these self-care behaviors is something to consider and look at. Then if you see the circle that encompasses the healthy coping, you have taking your medication, healthy eating, and being active. So many of you talked about exercise. Being active does not necessarily mean you have to have a structured program. Being active means you need to move more than you usually do. Okay, so instead of if you're watching TV sitting down and you want to change the channel, maybe you can get up and do that manually. Maybe you can just use the stairs more or park farther away. But for your patients, this might be an issue. But to the extent that you can increase some kind of physical activity, please do so. Taking your medication in the nursing homes, I guess this is the self-care behavior. You would perform more of this, and taking medications. This is an important behavior. Communication between staff is key to preventing some of these hypoglycemic reactions. And more about that later. And then healthy eating is the next one. People mentioned diet in the chat. Healthy eating, before, people would ask me, may I have a diabetic diet? 1280 diet. They used to have that, doctors used to order that 1588 diet, 1888 diet, but there's really no set diet for people with diabetes. We call it healthy eating. And healthy eating means, it means eating a wide variety of high quality, nutritionally dense foods in quantities that would promote, good health. So even though it's good food, doesn't mean you can have all you want. And that's what I have to always emphasize in some of my classes. They say fruit's good for you, and then people I teach would have like tons of fruits, and we have to have it in quantities that are optimal. And by the way, fruits, it has natural sugars. So that's something they have to be aware of as well. So that's what healthy coping is, eating a wide variety of high quality, nutritional dense foods. Now with diabetes, you do have to do some kind of carbohydrate restriction because that's what raises your sugars. And there are ways to do that. But I'm not going to discuss it right now, right here. Okay, so then we have the other circle encompassing these three. The inner circle, which has healthy eating, being active, and taking medication. These three serve as the basis for care plans, since they comprise what the individuals do to monitor the diabetes regularly. So we have monitoring in the aqua-colored circle there. Monitoring. It includes not only monitoring for blood sugars, but also blood pressure, activity, what you're eating, your moods. So it has grown to include other things. And it's important to monitor because by monitoring, it really helps change behavior. Monitoring gives you concrete evidence of how well you're managing. So I would encourage people to monitor as much as possible. And then the last two behaviors is circling the entire thing. We have problem solving and reducing risks. Reducing risks simply means reducing risk for developing complications down the road. So in the chat, some people mentioned getting your doctor, of course, getting vaccinations, being updated with your vaccinations are one of the things you can do to reduce risk, as well as, your yearly appointments with your eye doctor, your foot doctor. Those are important for reducing risks. Problem solving is a is a skill that where you utilize all your other self-care behaviors. Problem solving is asking yourself what the issue was, so you discover what the problem is, you come up with a solution, you initiate the solution, and then of course you evaluate the solution. That's what we have with problem solving. So these are the self-care behaviors, and this forms a framework for doing diabetes self-management education. So in your long-term care facilities, like I said, some of these self-care behaviors you probably perform, because key in this model to good self-management is involving the resident, the person themselves. So that's why you have the people in the middle. It's very patient-centered, and there's a lot of collaboration, especially when goals have to be established. So very patient-centered, and that's a nice thing about it. We can't change behavior without the person being involved in their own behavior that they have to change. And most often, healthcare providers tell people what they need to do instead of asking, well, what would you like to do and what is important for you and can you do this? And let's come up with some realistic goals. So that is the ADCES 7 self-care behaviors, and that's the framework that is used for teaching doing diabetes self-management education. If anybody has any questions, please feel free to type it into the chat. Okay, so let's move on to hypoglycemia. Okay, so those were we can skip that slide, and then this is the same thing. Another pictorial of how the ADCES 7 used to be presented. Okay, so now we have hypoglycemia. What is it? Here we have level 1. This is level 1, 2, and 3, and this is from the Standards of Medical Care in Diabetes 2022. This is the American Diabetes Association, and every year they come up with these standards of care. Throughout the year, if there's any important updates, they do notify us, electronically. So level 1 is when glucose is less than 70 milligrams per deciliter. Less than 70, where do they get 70? 70 is that level when people who don't have diabetes start to produce an endocrine reaction to falling blood sugars. So their neuroendocrine system kicks in, and the pancreas, the alpha cells in your pancreas put out some glucagon. Glucagon targets the liver to release some of its stored glucose. So the liver releases some of the glucose into the blood so that your blood sugars don't drop. So these are people who don't have diabetes. So this kind of counter-regulatory system is intact, and so they won't experience any symptoms of low sugar. But for people with diabetes, they don't have this. Their counter-regulatory systems, their hormones that help regulate insulin levels, blood sugar levels are kind of altered and not working real well. So they won't know that this is happening. So then you get into level 2, which is glucose less than 54. And where do you get 54? 54 is the threshold at which neuroglycopenic symptoms, and neuroglycopenic means a shortage of glucose in the brain. So when you start having a shortage of glucose in the brain, symptoms are going to happen. And what are some of these symptoms? You're gonna, well, first of all, there's shakiness, anxiety, sweating. When there's less fuel in the brain, there's going to be confusion, uncoordination, maybe slurred speech, might have a headache. Of course, you're going to feel hungry. You're going to be weak. So you have a lot of these symptoms already happening. Level 3 is when the event is so severe that you need assistance. They'll need assistance to correct for the hypoglycemia. And so severe, it can even include seizures and also death. I had a neighbor that ran to my house and called me. I ran to their house, and the father was already having seizures. And when the sugar was checked, it was 28. So I'm glad they called 911 already. But and he was okay. Now, the thing about having hypoglycemia, I just want to let you know, especially in the elderly, is if you experience severe hypoglycemia, it puts you at risk for developing dementia, and having dementia puts you at risk for having severe hypoglycemia. So it's a vicious circle. So when you can avoid this complication, the better off you are. And it can be mitigated, it can be avoided, hypoglycemia in the long-term care. And there's several ways that we can do that. So this is the glycemic criteria for diabetes. So let's just talk briefly about treatment. So what do? You see some of the symptoms. Unfortunately, some of the symptoms you see are symptoms that might be masked, especially for the elderly. Like you can see shaking. Well, if some of your patients already suffer from some kind of neurological, like, pre-Parkinson kind of symptoms, I mean, you can't use that. So, and then anxiety, nervousness, the baseline of some of your patients might be, they're just nervous to begin with, and they're always anxious. So you think, okay, well, maybe that won't work a lot. But the key here is, you take care of your residents, so you kind of know their baseline. If you feel and you see, and if you get a hunch that, something is a little bit off, by all means, and that they have diabetes, by all means, just check their blood sugars. When in doubt, you're never going to know if they're if they're experiencing hypoglycemia unless you check. So when in doubt, always check. And if you can't check, but you're in doubt, you don't know where the glucometer is, or I don't know where the strips are expired, whatever that may be, to treat the hypoglycemia. I would consider it a medical emergency. You can't have low sugars for a long time and walk around with low sugars. Not like hyperglycemia. You can deal with it for days, and people have done it for a very long time. But hypoglycemia, you don't get any glucose to your brain, you will suffer dire consequences. So that is the criteria. Treatment for hypoglycemia, we call it the 15-15 rule. I'm not too sure if you're all familiar with the 15-15 rule. That means you see some of these signs, you give 15 grams of a quick acting carbohydrate. So what's 15 grams? 15 grams is half a cup of juice, half a cup of regular soda, maybe 4 or 5 hard candy, a tablespoon of syrup or honey or sugar. The problem with treating hypoglycemia is people overtreat it, and then you have the rebound hyperglycemia. You really don't need much to treat it. This is all you need is 15 grams. So you do the 15-15 rule, 15 grams of carbohydrates, and then you wait 15 minutes, and then you recheck. And if the number should be increasing. If they're not increasing, you give another 15 grams of carbohydrates, wait 15 minutes and check. And if you check and it's still not rising, something else is going in there. So I would call 911. But this is the 15-15 rule. So when we talk about a quick acting carbohydrate, we're talking about, like straight glucose. If you have glucose tablets from the pharmacy, those are great. They work very quickly. But one of those tablets, I think, only have 3 or 4 grams of carbohydrates. So you're going to have to eat 3 or 4 of those tablets. The little like mint drops or hard candy, you might need 4 or 5 of those. Okay, so you just have to read the label. So it's always good to have a quick, a quick source of glucose in case you experience hypoglycemia. So that's how hypoglycemia is treated. Also, what if the patient can't, what if your resident can't swallow or is unconscious, right? So what do? Glucagon is something, it's an injectable, it's an injection. And it's really something you should have, especially if your residents have type 1 diabetes, or if your residents that are on multiple doses of insulin a day. It's always good to have a glucagon to help. And a glucagon is a hormone that would signal the pancreas to tell the liver to release stored glucose. So you need that glucagon. The injection is already, some kits are already pre-mixed, so you don't have to mix it. And there's others where you do have to mix the powdered vial with a solution. So you just give a shot, the entire thing into a person's size. And make sure that your glucagon kit is not expired. If it's not used often, it's not checked often, so it might be expired. So it's a good habit to check on some of your medications. So that is how we treat hypoglycemia. If you have any questions, please, type it into chat, and then Jesse can let me know any questions. Okay, a little bit about prevention. I talked about communication. Communication between staff members is very vital, especially with the person who's giving the medication. There's certain medications that will cause hypoglycemia. So some of the more common medications that you take for diabetes, the sulfonylureas, so that would be glipizide, glyburide, glimepiride. If your patients have these medications, that would cause hypoglycemia to occur. You usually take these pills before eating, 30 minutes before eating. However, if you give it to your patient, let your staff know that you had given this medication, so that yes, Kyla, there's also a nasal version of glucagon as well. There is. But back to communication between staff, especially the one that's giving the medicine. Let them know when you have given these pills, so that staff can make sure that the person has had some intake, so that hypoglycemia won't occur, especially if they are getting insulin. Now, there's different types of insulin. There's a quick acting, there's a regular acting, there's an intermediate acting, and there's a long acting. And each have a different onset, peak time, and duration. So if you give these intermediate acting insulins, and I find that they do, because the regular and intermediate acting insulins are cheaper. While some of the other ones are probably better and easier to work with, these are cheaper, but you can still work with them, like NPH, which is an intermediate acting. You give the shot, maybe it starts being effective an hour or two after the injection, but it doesn't peak until anywhere between 4, 5, 6, 7 hours after it's given. So if you give the shot in the morning, you're going to have to make sure and communicate with staff that 4, 5, 6 hours later, it's really going to peak. So your resident would have to eat something. So some of that has to be communicated. And it's important for you to be in tune with your residents, because you don't know if their peak time is like 4 or 5 hours later. Because I've had different people in my classes say, I know I feel it at 4 hours. I feel I'm really hungry now. Someone says, I feel it at 7 hours. So you really have to be in tune with the residents when, when the peak time for their insulin dose occurs. So communication is important between staff. Sometimes, you might have residents that just don't like to eat. And some of these insulin shots should be given before they eat. And if you're having issues with them eating, I would be very cautious about giving it before they eat. I would probably say, no, I'm going to wait till especially if it's the longer acting insulins, just make sure they had eaten. But the shorter acting ones, maybe you might want to give it after they had eaten, so you know how much they had eaten. But that's something you have to discuss with your provider. So definitely communication between staff as far as medication and meals and intake of meals is very, very vital. Let's see, the meals, like I said, that has to be communicated very well. The use of continuous glucose monitors, I don't know how common they are in your facility. They're called CGM, continuous glucose monitors. Those are real lifesavers, especially if you have type 1 if your resident has type 1 diabetes, which, by the way, Medicare does cover for CGMs. if you do have type 1 and if you are on multiple doses of insulin. The continuous glucose monitors really avoids a lot of the finger sticks, and you can check glucose any time of the day with a reader. You can also download it depends on the type of the model of your CGM. You can download an app on your cell phone and use that to read any results. Other CGMs, they have, there's features where you can set the glucose levels to alarm whenever they're less than 70 or higher than whatever, 180 or whatever, 200, whatever the provider decides to do. So these CGMs are a real lifesaver, and I find them very useful. But like I said, I don't know how common they are in your facility. Here in Guam, they're not real common, unfortunately. But if you can get something like that for your resident, you save yourself really a lot of trouble. In the resource page, I believe I have something there from the AD, and we'll talk about me later. Oh, but maybe we have to talk about me because we're running out of time. Okay, so that's what we have for hypoglycemia. If you have any questions, type it in, and then we're going to talk lastly, what about me? Okay, so what about you? Like I said, November is National Diabetes Month. Okay, 38% of the adult population have prediabetes, and 80% of people don't even know it. So more than 1 in 3 people have prediabetes. It's important to know what your risks are. It's important to find out if you have diabetes, because self-care is important. You need to take care of yourselves before you can even take care of your residents or your family. So I encourage you at this time if you see this next slide, this is put out by the CDC. It's a risk test for prediabetes. It will take less than a minute. You just answer all those questions, and then you tally up your points. If you have 5 or more, you're at risk for developing prediabetes. There's also in the resource page a risk for developing diabetes, and it takes just less than a minute, and it's an online thing, and they give you the results right away. So please take this test to see if you're at risk, that you can do something to help yourself in the long run, because prevention is certainly the most effective and cheapest way to take care of ourselves. So be good to yourselves. Find out what your risk for developing prediabetes or diabetes is today, especially since November is National Diabetes Month. So that's all I have to say. Oh, I forgot to add, I'm sorry. I forgot to add, it's important for your facility, if you want to have an alert system for notifying medical providers about patients' blood sugars. The American Diabetes Association, in their standards of care, do suggest they call it an alert strategy, that you call the provider immediately when the blood sugars are less than 70, and you call the provider as soon as possible in situations where the glucose is between 70 and 100. Or if the glucose values are constantly above 250 over a 24-hour period, you call the provider. If glucose values are over 300 over 2 consecutive days. So they say 300 because if you check at 300 and you check later down to 180, and then maybe went to 250 and it's down to 140, but then it goes up to 300 in a matter of 2 days. That's showing wide sugar excursions. You don't want to have these wide swinging sugars. So adjustments in their medication would have to be made. And if you check your blood sugars and it registers high, you really should notify the provider as well as soon as possible. If your resident is sick and vomiting, having diarrhea, has some symptomatic hyperglycemia, you might want to call the provider also when you have a resident presenting like this. So that's an alert strategy for nursing homes. And it's good so that staff know when they should call their providers. And that's it. Thank you very much, guys. I'm sorry I went over time, and I hope you found this helpful.
Very helpful. Thank you so much, Aggie. This is so much wonderful, great information that certainly aligns with National Diabetes Month. So we really appreciate you joining us all the way from Guam in the future. And thank you, Kyla, as well. I do have just one question for Michael while we have you still on the line. I know you've had power issues. Out of curiosity, if you guys are using those Freestyle Libre monitors, whose phone are you using to read the data? Are you using a house phone or the resident's phone? How are you managing that? I know that has come up as centers have looked at using more of those devices, continual monitoring devices, but there's been an ongoing concern about whose phone do you use? And we might have lost Mike. Oh, residents typically have their own. Okay. All right. That's what I was wondering. Okay. All right. Well, again, thank you, everyone. Thank you for hanging on. Great information. Thank you to our wonderful speakers. See everyone next week, November 16th. Same time, same place. Take care. Be well.